and in particular, this one today is going to be thinking about remote healthcare systems and whether this is, as I say, a new normal. I wanted to just sort of start really by sort of declaring that I'm not an NHS professional, I'm not an NHS expert in lots of ways. My background is that I'm an organisational psychologist. I'm an organisational psychologist, and my background in research is rather interdisciplinary. So I've worked with medics, and I've worked with broader business professionals, engineers, and so on. And my own interests really are particularly around the design of work and jobs. So that's kind of my backdrop, if you like. Okay. So let me just move on to this next slide, but just to sort of declare how I'm going to manage the agenda, if you like. So really the purpose of today is to think about a project that I was part of back in 2011 called the MALT project, which is short for Mainstreaming Assisted Living Technologies. And over the last few weeks, with everything that's been going on with the COVID-19 situation, it's got me really thinking about how relevant that work that is almost 10 years old now really is in today's day and age, and in terms of dealing with the potentially thinking about some of the issues we're facing around COVID-19. So really the purpose of this talk is for some discussion, hopefully, and thinking about the MALT project, what we were trying to do back in 2011 to 2014 when that project finished, and to think about why the lessons that we learned in the MALT project might just be relevant for those trying to navigate the current crisis. And in particular, I'm going to try and do that by thinking about how the landscapes for the MALT project and COVID-19 are actually more similar than you might think, and perhaps some of the ways in which COVID-19 is actually a little bit different. So that's what I'm going to try and think about today. The first thing, so as I said, this really got me thinking a few weeks ago now, when I started seeing these headlines all over the place. You'll have seen lots of these, but these are just a couple of many. So people talking largely around how coronavirus is changing the NHS overnight. So this quote here on the left, many people within the NHS are talking about how 2 years of transformation is being done in 2 weeks. And I thought, wow, that's exciting, because back in 2011, this was still available. You know, there was lots of the stuff that we're really talking about today. We were talking about nearly 10 years ago. So what is going on now? Okay. So these kind of headlines, there's lots of discussion around lots of new apps and new technology. And I started to think about, well, what kind of changes really are being talked about at this point in time? And there's lots of discussion, particularly in the media, around teleconferencing. So the use of Zoom, for instance, in the health service is being used for meetings, for patient clinics, so meetings both between other colleagues in the NHS, but also for patients. Lots of discussion about perhaps different apps, different devices and technologies that are available. And then lots of talk about, I guess, the sort of really innovative new big stuff, that, you know, things like, you know, I've seen stuff around glucose implants. And I've been hearing about, you know, things like you can implant somebody's a glucose reading, and that can be read on a phone, you know, implants into somebody's body. So all sorts of really cool stuff like that, and also lots of stuff around digital analytics being used to kind of help with strategy and forecasting, so bringing together even things like AI technologies and so on. So there really are lots of broad changes. But one of the things that keeps sticking with me, certainly in terms of my own thoughts, is that actually often the technology that people are talking about isn't actually radical. You know, things like Zoom, for instance, they're not necessarily particularly novel or new from a societal perspective. What is novel, though, is their use in a healthcare context. And so that got me really thinking about the fact that this actually takes us right back to, you know, our own project on the mainstreaming of assisted living technologies. I realise we've got people here from all over the place and with lots of varying degrees of expertise in this. So forgive me for a moment if I just sort of recap for those of you who don't know about what this actually is. I have a video here that I'm not going to show you, but we will circulate the slides for everybody, so that, and you can follow that link to view this in your own time. But there's a short video there that is available to just show you the kind of ways that assisted living technologies were being used back in 2013 when we were doing the MALT project. And assisted living technologies is really a broad term that's used to cover things like telehealth, telecare, but it's basically the use of any sort of modern, unobtrusive electronic device that's put in somebody's home to help provide data. So that professionals and carers can help monitor somebody remotely to help them perhaps stay independent, safe and healthy. So the kind of things you might include within that, or at least we were back in 2011, were things like remote glucose monitors, blood sugar monitors, remote blood pressure monitors, and lots of similar sort of kit like that. And the kind of ways that these were being used back then, these images, they look a bit dated now, but these are images from the project back in 2011. But what was happening even back then was, you know, people who were particularly vulnerable, so perhaps elderly people living in their own home, perhaps with a chronic health condition or a longer term problem like dementia, things like that. People were having this kind of kit installed into their homes, and then they could be monitored remotely, perhaps in a call centre or by healthcare professionals, either within the health service itself or outside the health service, having to look after these people. And very often what would happen is they'd be taking their data remotely, that would be fed back into an automated system that would then be monitored by somebody often in the NHS, perhaps a nurse and their team. But they'd be monitoring how they were doing, and if their vital signs dropped below a certain level or increased above a certain level, they would bring them into clinic and talk with them. Now, the benefit to that kind of approach back then, there was a whole business case that was being put forward, and in many ways, this is really not dissimilar to today. So back then, there was this statistic that kept being shown to us and seemed really powerful, which was the fact that 5% of inpatients accounted for nearly 50% of all inpatient beds in the NHS. So that's a really small proportion of people taking up quite a lot of resource, and the reason for that was because they were often not being well managed, or had lots of long-term conditions that were trying to sort of keep under control. Underpinned by the fact that, you know, high numbers of adults, and these figures are more current, but NHS Digital has shown that, you know, 43% of adults have at least one long-term chronic condition. That increases even higher if you're over 85. All sorts of other figures about the amount of people that need help with their daily living. So lots of older adults, 27%, need help with at least one activity for daily living. And 26% of those need help for instrumental activities in their daily living. So that's things like getting dressed, making food, making drinks, and so on. So there was a real case for how can we support people outside of the National Health Service. Another set of figures that back then were quite compelling were the fact that, you know, someone dealing with a single long-term condition might, during the course of a year, get around 3 hours of clinician time. But actually, if you look at then what they're left with for the rest of the year, they're looking at huge numbers of hours that they have to actually self-care. And the access to telehealth and assisted living technologies at that point in time was very low. So, you know, you were talking around about 5,000 people benefiting from telehealth services in a nation where at the time 17 million people were living with long-term health conditions. And alongside, in fact, slightly before our project, there was other research. So the whole system demonstrator, which was this huge sort of clinical trial, had found quite compellingly that where you did use assisted living technologies, annual mortality rates improved, hospital beds fell, there was a reduction in elective admissions, so that's fewer people in the you know, A&E services, for instance, and a reduction of bed days. So there was really quite a compelling case to try and utilise these technologies. again, I've kept these in just to show you, but even after our project finished, that picture hadn't really changed huge amounts. But in terms of how available technologies were, but certainly there's a real interest in people being able to utilise these technologies to help monitor and improve their own health outcomes. So we were part of that kind of context back in 2011, and the MALT project was a 3-year project. As I said, began in 2011 and 2014. It was a big project in the sense that it was £1.2 million worth of research funding, and our team at Leeds was working with a big team at Sheffield, and other organisations like the Advanced Digital Institute, who were able to help us create a panel of industry, quite an impressive industry panel with over 50 members, which included lots of the big technology providers at the time. And the purpose of our project really was to start to look at how ALTs were being deployed within the NHS, and we were focusing in particular on 4 sites. The research overall took very much a kind of collaborative approach, an action research approach. So really what we were looking to do was understand what was already going on, and then to try and understand actually how we might mainstream that. So there were lots of pockets of excellence. Actually, they still weren't being mainstreamed in any sort of widespread way, and our research was trying to understand how you might go about broadening out and widening the scale and use of ALTs. Our research collectively, so as I said, there were 3 different, well, there was a number of different research strands. I'll come to ours in just a moment, but collectively we worked with a full range of stakeholders. So we worked with people within the NHS, commissioners, doctors, nurses, frontline staff, physios. We also worked with lots of carers and patients, and also the people developing and selling the assisted living technologies, so those business professionals as well. We undertook across the sites, you can see here, a large number of individual interviews with different stakeholders, so nearly 160 interviews in total during the research project. And this is across the full scale of the project. And we also did a really large number of scenario planning workshops as well. So these were workshops where we were looking at individual sort of with smaller groups of key stakeholders to try and understand actually what they wanted and needed from the ALT situation. So that's kind of a really broad view, and there's lots more detail. I put on the previous slide the link to the MALT project, which is obviously now an older project, but there's still a website available there if you want to know more about the actual methods and approaches. But just to say, so our particular perspective within the MALT project was to think about the organisational models, if you like. So how does, there were people looking at the economic models, how this could be scalable. There were people looking at the particular barriers and facilitators of mainstreaming ALTs from a kind of frontline staff perspective. But we took the view that we were working out of a research centre known as the socio-technical centre. And our approach, really our perspective, is very much that technologies are really important, but they shouldn't be the sole driver of change. If you want to create change, you need to also think about the knock-on impact that the technologies, the change, the business models all have on that wider social system. So if you think about this sort of hexagon on the left-hand side, you know, the technology, this blue node at the bottom, is just one part of the infrastructure, and that changes the way people do their work. It changes the culture, it changes the processes and practices you need, and so on. And our project was really taking that perspective, and in particular, we were tasked with thinking about, so what does a business model, what does an effective set of business models look like? And a business model is really, you know, how an organisation seeks to make, create value from the change it's seeking to implement. And for us, there was lots and lots of talk about how technology could save lives, technology could be used, it could be scalable, it could create efficiencies. But actually, we considered that the business model and the service model, so actually the way that care is delivered, is inextricably linked. You can't just sort of have a business model without thinking about the knock-on input that that has on the service model. Because when you do sort of make those decisions, you're also changing the way people are asked to do their jobs. And as a result of that, we take the perspective that multi-stakeholder involvement is really, really important. A couple of the kind of, for those who are interested in socio-technical systems, a couple of principles that underpin that approach are this idea that, you know, when you're trying to make any organisational change, pull works better than push. You know, people need to own that change. They need to feel part of that change. And so you need to involve key stakeholders, and the changes need to be, you know, changes that people want and understand and need. It also needs to be holistic, so you need to understand how people's, how the social and the technical aspects of this system are related. And when you do think about changes and think about, you know, implementing new technologies and related changes, you need to also think about mapping out the sort of systemic durability and robustness. So what happens when aspects of the other parts of the system change? So they were kind of our perspective, and I just want to spend really some time just thinking about, so what did we learn from this? And again, I'm happy to talk more if we don't get through some of the details of this in this session. I'm happy to approach it in the discussion afterwards. I'm going to talk about three key lessons really that we learned. The first is that, as I sort of briefly outlined before, the business model being used to adopt the technology hugely affects the design of the service. And I just want to make a couple of points to kind of reinforce what I really mean by that. When we approached our research, we worked, as I said, across 4 different sites, and we expected in the first instance to find lots of variability in the way that people were using assisted living technologies and telehealth. And what we actually found was that there was a huge amount of commonality. So an example of this is that in 2011, the vast majority of people in the NHS were working with a kind of buy rather than rent or lease model of procurement. So what this typically meant was that organisations would be able to they would be able to sort of access a small budget as a test budget, and they'd be able to typically buy maybe 40 pieces of kit, if you like, which would then be deployed in patients' homes. They'd monitor their vital signs. Typically, they'd be installed by clinical staff within the NHS, and then the equipment would be used over time by patients and their carers. That data would be collected and reported to a clinic. And then, as I briefly mentioned before, clinicians would monitor those readings, and if they fell outside of a normal range, they'd perhaps be brought in either to clinic or to discuss over the phone. And typically what was happening was that those pieces of kit operated in parallel with existing services. So there wouldn't be any provision for maintaining or storage initially of the kit, and they'd have to think about, well, what do we do if, you know, once this kit's not being used in that home anymore? Who's going to service it? Do we pay for that outside, or do we include that within the original deployment? And what we found was that actually, even though this followed a quite standard sort of process of being referred, installation, monitoring, removal and storage for each patient that was enrolled in the telehealth scheme, in actual fact, it raised lots and lots of questions about the service model and how that would be, you know, how that would operate in practice. So this idea of buying rather than leasing meant that actually suddenly there were lots of questions about how to refer patients into the scheme, who was going to be selected, how was it going to be installed. You know, suddenly people who are maybe clinicians are now installing kit and travelling to patients' houses. How would the data be managed? You know, suddenly you require a call centre that you didn't need before, and suddenly the nurses that may have been used to visiting patients face to face have suddenly got to monitor data from a distance. And then once that patient's not using the kit anymore, how's the data removed? You know, how is the patient discharged from the system? How is the equipment stored, cleaned, repaired, and who does that? So it raised a whole sort of breadth of questions about the service model, which we found would have been very different had they have gone down a leasing model, for instance. And we called this in our research, we called these design dilemmas, which were part of really the complexity, we call that sometimes the wickedness of the problem. So really it depended, and I won't go through all of these in depth here, but you could see all the kind of decision dilemmas that were going on at each point in the application. So when people are deciding how they're going to use telehealth, even just to start with, there was lots of questions about, well, is this going to be fully integrated in a service? Or will it be a standalone service? Are we going to do this in-house? Are we going to have to outsource some aspects or all aspects of this? And if we do, what does that mean for all sorts of things like, controversially, does this become a privatisation of the NHS, and what will that mean? There were lots of questions and concerns about, is telehealth an expenditure, or do we consider this as a saving? And all of these affect the way that the decision and the organisational model develops. We also found that actually each of these dilemmas, each of these choices were associated with lots of individual dilemmas even within them. So, if you just take one of those previous points about, do you do this in-house or do you externally resource things? Each of those in their own right raised various questions. If you externally resource it, suddenly you've got to think about how people trust that data. You've got to think about relationship management. Suddenly you've got a new partner involved. When you externally resourced it, there seem to be lots of greater opportunities for scalability, whereas in-house, if you've only got 40 units of kit, how do you manage those 40 units? And what if you suddenly have 300 patients that need them? So you can see that there are all these kind of, we call these design dilemmas. And so that's the first lesson that we learned, that the business model and the service model are really inextricably linked. The second lesson that I just want to share with you is that this idea that actually the introduction of a new technology, however small, whether it's literally something as simple as introducing Zoom as a video conferencing technology, or whether it's something much more widespread like introducing an ALT system into the clinic, the introduction of a new technology necessitates change throughout that socio-technical system. I've taken here the original hexagon that I showed you just before, just to illustrate the kind of challenges and how these things interrelate with each other. At the time that we were looking at our research around ALTs, there were, for instance, lots of really quite fancy and novel smartwatches available that did lots of the things that some of the ALT equipment did. But the NHS found that really difficult to work with because of interoperability issues. It didn't maybe work with their computer systems. There was reliability issues, which actually, if we look to this other section on increased workload, there was quite an interesting byproduct of people's concerns about the reliability of the technology. Meant that actually, instead of finding the efficiencies and reducing the number of patient clinics, for instance, that they had, so the idea being that, if we know how people are doing all the time, we can reduce the number of clinics we need them to attend. And in actual fact, the counter opposite happened. People didn't trust the technology. They were really worried about taking risks. And so they ran the clinics in addition to collecting new data, which meant that they needed two roles. So they needed one person to monitor the data and another person to run the clinics. So you can see that all of these things are very much interrelated. The NHS commissioning process meant that actually for lots of businesses, it was really hard to engage with the organisation, the NHS organisation. There were all sorts of questions about, well, how do you even know if this is working? What metrics are we going to use to measure success? And that created lots of challenges with engagement, with staff and with patients. So you can see these are all hugely interrelated. And what particularly stood out was the uncertainty that this created for people working within an NHS environment and the huge impact that that had on the culture. So this wasn't something that people were used to. And at this point in time, that uncertainty really impacted on people's ability to think about what the future might look like within a health service that cared remotely for patients, even if it was just as part of the overall service delivery. So the third point that I just want to sort of raise here is that what we found and what really was highlighted throughout our research was this idea that collaboration between stakeholder groups is absolutely fundamental. What we sort of recognised very early on is that collaboration is completely imperative to service delivery. So within an effective healthcare system, it's really unusual that any single person has the complete picture. People in healthcare systems have to work together. And so healthcare is a social process. It involves knowing who to seek advice from and information, when to do it, and so on. And what was really interesting about that, as far as the implementation of remote healthcare was involved, is that actually all of these stakeholders tend to see the world pretty differently. We found that in our workshops when we were looking at how people were measuring success. So, actually, what does success for AIDS look like? There were, I've put in this table on the right, various different views about what success looked like. Are we talking about reducing costs? Are we talking about improving health outcomes? Are we talking just, more straightforwardly about improving patients' quality of life? Are we talking about all of those things? And what we typically found is that different stakeholders see the world differently, depending where they're stood around that sort of elephant, if you like. And particularly importantly for me was to recognise that different stakeholders have different values and different needs, different rationales for using ALTs in this case, and will evaluate the success differently. And again, you can see that, if we look at what did our stakeholders value, our doctors and our carers were really trying to use this as hoping and aspiring for it to help them manage heavy workloads. But they've got this real, concern with not taking risks with patient care. Patients, on the other hand, really valued clinician time. They really valued that face-to-face contact. Equipment providers, on the other hand, whilst valuing all of those things, also really needed to find a way to make, to create revenue through this equipment. So everybody's looking at this slightly differently. But what we did find, and I'm going to try and just skip through some of this, and again, this is available more publicly if you're interested, is that even when you looked at, creating that conversation between different stakeholders, there were some preferences. So most people didn't like the idea of just having a complete free-for-all in the NHS. They didn't feel that for anybody, a complete open market with no active role in procurement would be good for the NHS. They also didn't feel that it would be useful to have really small user groups all doing something completely different. And there were these common ideas about, the use of having centralised services where possible, having large numbers of users, and perhaps having networks of different technologies available for different people. So just briefly, because I'm aware of time, I want to sort of leave that there for a moment, but just think about how today's landscape, for me at least, is different. And I think some things are really key in the differences now with this situation with COVID-19. So first and foremost, what is really different to when we were working with the MALT project is that there is an immediate pressure. There's that pull that I talked about right at the start of this presentation. It needs to happen. People can't deliver healthcare without it. And for the first time, what we're seeing is the public that is actively engaged in that process. So for the last, when we were involved in 2011, convincing patients that they might be seen in a remote setting was, really unheard of. It was a completely different way of working. Whereas today, what we're finding is that people are staying away from A&E. They don't want to go, that face-to-face value, that's the face-to-face contact that's been so important to them, at least in the moment, is of a lower priority to them. So people are feeling that need, and they appreciate the risks that are different. I also think what is different today is that the stakeholders and their values, it would be interesting to understand whether they are different. I was talking to a medic actually only yesterday who was talking to me about how the risks and benefits are so different in a situation that they're facing right now with COVID-19. These kind of priorities that people would have been balancing before about not taking risks by not seeing a patient would be more of a risk than seeing them too often. But in today's climate, bringing someone into a hospital who's perhaps already very vulnerable is very, very different. So those stakeholder values are perhaps changing and may be different. I also wonder if the measures of success may be different. So, the measures of success for ALTs previously were all about, it's sort of reducing immediate costs, whereas cost is very much secondary today to thinking about you know, how it perhaps was back then. So you know, costs versus you know, the risks and lives being lost to COVID-19 may tip that balance, I think. So I think we're seeing quite different measures there. We're also, and this is much more unprecedented, seeing very different bureaucracies in the NHS, I think. And as I said at the start, you know, I'm not an NHS expert here, but I think even just by looking at what's publicly available, you can see here that the hurdles that people in the NHS are having to go through are perhaps different. So, you know, there is perhaps an open ear in government that perhaps there wasn't, or at least wasn't at the level that there is now. And I think there is a public persuasion and a willingness to put behind the National Health Service appreciation for its staff, and also perhaps alongside that resource. You know, we want our NHS to work. And some of these risks benefits that I was talking about, perhaps we're more willing to appreciate a compromise and accept change. We also have very fundamentally an engaged public. You know, the efforts we've heard lots about. You know, we heard Boris Johnson say that he would level with us, that lives would be lost. You know, this is engaging with the public to explain to them that there are risks and that these need to be managed. And I think that active persuasion is rather different. And again, if you look at that in relation to what I was talking about before, all of these aspects of that system are different in today's situation. If you look even at some of the data that's beginning to come out, we're seeing unprecedented levels of you know, people enrolling in prescribed systems, the electronic prescription system, for instance, so that they get their prescriptions remotely. Lots and lots more people using Microsoft Teams already than there were before. So I think this is, for me, just part of a slide of change. And I do wonder whether that will be sustained, because I think when people, part of the barriers that we saw before were people concerned about making these changes. And I think once some of those changes have been experienced and they've seen it firsthand, perhaps that helps with some of the culture change that maybe was needed back in 2011. So some conclusions just really before we open a discussion, hopefully, is that really what can we take from MALT? Well, for me, I think there are some key sort of things that we can take. The first being that you need to bring those stakeholders together. Very often in the NHS, the change comes from the top. People, you know, a decision is made that there will be, you know, this is how we will procure, this is how we will work. And actually, I think understanding the stakeholder needs throughout the system, and that includes people on the front line, what they need from it, what carers need from remote healthcare, what do patients need. I think understanding those collaboratively to understand design requirements, goals, and actually just fundamentally what people value differently will be important, and will help actually to anticipate and resolve problems before they happen. I think it will also be really important to bring people together to help identify their preferred ways of working. And when I say that, I mean the organisation, the NHS organisation, but also with the business providers and the technology providers, because those technologies are moving usually considerably faster than the healthcare system is. Also, we need to appreciate the wickedness inherent in this problem and nurture that socio-technical culture change that I think has been long needed within the NHS. So recognising that actually where you do make that change, there will be a knock-on throughout the wider socio-technical system, and understanding what those changes might be, so that you can sort of try and understand those knock-on effects. And then finally, I think there are toolkits available out there to help organisations make use of a socio-technical mindset to help with the deployment of change. And I think that is more useful now than ever, you know, and so important as we move into potentially a future where this becomes much more normal as a way of operating. I'd like to open now into a discussion. I can see that there are already some questions and thoughts. I think Sarah's just noted here. I'll let Sarah speak for a moment.
Sorry, so I mean, I can speak to you all, and hopefully I would like to host the questions for Helen, but unfortunately she can't hear me. So if I could invite you to put it in chat, and then she will be able to answer them.
Yes, at this point here about at present, the drop in attendance probably includes people who really shouldn't be staying away. Absolutely. Longer term, though, the move to adopting the right places, e-prescribing will probably stick. Yeah, I mean, I think you're absolutely right, and I think it is important to think long and hard about actually whether this is suitable for all services, because I think some of these things. Perhaps aren't. I know in the run up to the presentation, some people asked questions or raised in their registration that they were wondering whether this was suitable, for instance, for mental health clinics and similar for similar services. And I wouldn't like to, be the person to judge that, because I think that's really where stakeholders need to be brought together to answer those kinds of questions. And I think the best way to do that is to understand what it is that people value about the different aspects of the care. This is an interesting question, actually, about the healthcare education and what the key things are that I think needs to be assimilated into HE curricula. Personally, I've taught a little bit in executive education and worked with healthcare professionals in some sort of groups and settings, and I think more broadly speaking, it's that appreciation of socio-technical systems thinking that isn't necessarily well understood. I think people sort of intuitively recognise that systems thinking is important, and people talk about systems thinking as being important, but I don't think they necessarily realise that actually there's an evidence base behind that and a tool set that can be used to help with scenarios planning, for instance, at a more strategic level. And I think that also people often think that really leadership alone can solve this, and I think clearly there is a real place for leadership, and I think that needs to be taught within higher education curricula. But I think an appreciation that actually leaders and followers need to work together, because leaders alone can't make the change. They're not on the front line. Those leaders need to have ways to appreciate and understand different stakeholder views. And I think that really could be better taught in healthcare education. Yeah, okay, and just to kind of look at some of these other comments here, do I think technology will allow overseas healthcare providers to enter the UK market? Again, I don't really know the answer to that, but I think that that has always been a source of perhaps opportunity, but certainly concern, because I think in my experience when I was working on this project, there was a lot of the time whenever the discussions around healthcare technology and remote technology came about, there was immediately lots of concerns about ethics, data protection, about concerns about data sharing. Certainly now there's lots of concerns about 5G and all of that stuff, and I think that at the moment that perhaps has the opportunity to dominate the conversation. Certainly in some of the tools that we were working with within the MALT project, we were trying to get people not to rule stuff out before we'd really understood the scenarios that were possible. So very often we're quick to sort of jump with the problems without looking at what the opportunities are for working through that system. But we absolutely shouldn't just sort of ignore that challenge. But I think it is something that we could potentially see and could potentially see work. Yeah, and thank you, Ruth Evans here, who said that there is some that the evidence on mental health is mixed, and some remote contact has been found to work. And you're absolutely right. I think, though, you can say this for almost all areas. Certainly, we were working with people who had chronic health conditions, like diabetes and chronic lung problems, for instance. And actually, at the start of the project, a lot of the barriers that people talked about were that you couldn't possibly do this for this particular group of people, and there were all sorts of reasons given. By the end of the project, actually, there were some really brilliant examples of this working really, really well in practice, because those barriers have been sort of addressed through those processes of collaboration, as I've talked about. So perhaps there are opportunities that aren't currently being explored. Yeah, this point here about educating the public about new ways of working, I absolutely agree. I think as I was preparing for this talk, one of the things that I started to look at is some of the news items, and I wanted to understand, how much has changed since our project finished in 2014. One of the things that I was quite interested to see was that the discussions prior to COVID-19, even in 2019, 2018, and so on, were all very much trying to sort of gently persuade people. So there was there's been some articles, for instance, by NHS Digital and others in nursing journals, for instance, and the health services journal, where they've sort of gently been trying to sort of advocate for the benefits of telehealth, and I think that that's really useful, of course. But I think what they've lacked perhaps is examples of this working really, really well in practice. There are examples of that, but I think the public genuinely probably don't know too much about it. And yeah, I'd be, and I think colleagues of mine would be very keen to assist those processes. We did do at the end of Malt actually some quite nice. There were some quite nice videos prepared. If you go onto the Malt's the Malt's webpage, which I can direct people to. If you go to that page, there was lots of discussion there about, there was lots of really nice short soundbite videos that we did. We also did lots of fact sheets about sort of mythbusters, but I think there's definitely a place for more of that. And I think it's also fair to say that some of that could now be out of date, because a lot of the technology is developing, has continued to develop over that time. But I think the biggest barrier still remains how businesses and the NHS collaborate to make things work. I know, for instance, that Zoom has had some success from the fact that it's offered it for free. So the costs are negligible at the moment for the NHS to use these technologies. So obviously that gives it a test base. They can trial it, see if it works, and then find ways to make it work and integrate. Obviously that's not going to be possible for absolutely everything. But I think there is certainly some merit to educating people, showing them what can be done, and then helping them to work through that collaboration, how they can embed it into an existing and developing socio-technical system. Yeah, to this point about Zoom not being safe enough, exactly. I mean, as I say, I'm not a medical professional. I haven't, I've only had meetings with other medics using Zoom, and so those things do have to be definitely thought through, and I'm not here to advocate for particular technologies or to think about how good particular technologies are. And of course that's one of the barriers to this being mainstreamed, if there is a perception that something isn't safe enough, whether or not that's true, and it may well be. I think what's really important is to have that conversation, because very often the concerns of different stakeholders are not fully understood by one another. I know, for instance, when we were doing our project, one of the things that people were really concerned that we shouldn't have patients in our planning workshops, because they didn't want the NHS vulnerabilities to be exposed. And we were very clear that actually they're a key stakeholder. They absolutely should be involved in the discussions. And what we found was that by involving patients and their carers in the discussions, even though they're very vulnerable individuals in lots of cases, they actually became champions of the changes that they were trying to make. So yeah, I'm certainly not an advocate for particular technologies. Am I aware of similar research on a more nationwide level? No, I mean, this is At the moment, I'm not. I'm sure there is stuff like this going on. I think, I mean, it was interesting. At the end of our project, we had a great big sort of dissemination event, and what was coming through in some of those discussions was that lots of organisations were just finding it really hard to engage with the NHS for various procurement reasons. And so a lot of the kind of best practice innovations were happening within either private hospitals or within the private care social care sector, and that was kind of trying to drive some of those changes. But there certainly will be things. I know in 2017 there was a really interesting project that I want to say was happening down in Surrey, that I remember seeing on the news, about a clinic that had been able to embed telehealth services in their dementia care work, and they'd been able to install lots of remote monitors throughout people's who were patients, and it was enabling them to live much more independent lives for longer, because people were able to sort of monitor the equipment that was were able to monitor people's behaviours. So, oh look, this person hasn't left their bedroom today, perhaps there's something wrong with them, and then they'd bring them in. Or perhaps there's somebody who hasn't used their water. Even water firms were enabled to create sensors and check, well, actually this patient hasn't left their bedroom today, they haven't used any water, what does that mean? And somebody would be triggered to come and visit them. I have seen some pockets of really excellent practice with that, but I don't know much about them to be able to help here. Yeah, and I think you're right, a lot of it hasn't taken a national approach. There is a lot, and I think that's largely because so many of these trusts work so independently, and as I said, a lot of the money we were finding was being used was that it was, people were able to secure money for a trial, and in fact that's quite an interesting point, because what we found at the time we were doing our work was somebody might be able to, for their clinic, put a case together and say, right, we've got 40 units of kit here, and these can be deployed. But then what was quickly happening was those bits of kit would go out, they were bought, so they'd have to pay extra for those to be serviced and stored and so on, and so very quickly they'd become obsolete. Then they wouldn't demonstrate impact that they were hoping to demonstrate, and then they wouldn't be able to put a further case forward for more. So what we were finding was that actually the business model was really limiting the impact that they were being able to demonstrate through the work. And so I think that was limiting a lot to tests and small level projects rather than national approaches. And I think you're absolutely right, just to pick up here Ruth, I think you're absolutely right that NHS Digital, I think, is probably a bit of a game changer as well. Because there is lots of work that's proactively being done by that team, which weren't, certainly in the form that they're in now, working when I was working on this project. And thanks, Sarah. So a question here about the permanency of these changes. Yeah, so I think that often we talk about digital as being radical and new, and all these sort of more. I mean, I was reading the other day stuff about robotics and how you might be able to use 5G for doing robotic operations across continents, opportunities for people to do virtual, as I say, virtual surgeries, virtual clinics, and I think that there's all sorts of data around big data, cloud technology, and the kind of explosion of data capture that we're seeing. I think there are some huge opportunities going forward to enable people to link together data in ways that aren't currently linked together, and to kind of use technologies that are more widely available in society. So I'm thinking things like computer simulation. Can you use things like simulation technologies to simulate hospital wards before you make changes to them and so on? We're certainly getting involved in that kind of work here in Leeds. But I think those kind of radical changes are still quite a way off. I think we're still going to see quite a lot of resistance to that for all of the reasons we've talked about earlier on here. I think the biggest opportunity at this point in time is the pull, and to kind of capitalise on that pull that we're currently seeing in the workforce, and also to capitalise on that goodwill that we're seeing towards our healthcare system at the moment. And I think at the moment, people really appreciate and understand that there is a need for a remote clinic, for instance. And I am talking anecdotally here, but I have heard lots of friends and colleagues of mine talking about how they've perhaps had a remote virtual clinic with someone earlier, and that actually was much more that was actually completely different to what I expected. I've also talked to medics who said, oh, I was really resistant to the idea of doing a virtual examination of a patient, but actually it's working better than I thought it might. So I think people will look at that and see some amount of opportunity for more permanency in those changes. I would imagine that you might see opportunities certainly for general practitioners. So I've certainly heard talk about how appointments are easier to get through. People are finding that actually the calls and so on they're finding it easier to run those clinics, getting through patients perhaps more efficiently. I think some of the risks that people talked about earlier, are we going to miss cases of cancer because of this? Are we going to miss heart attacks or potential strokes? I think some of those risks are going to, will sort of make or break some of these services, but I certainly think more of it will stick than we've seen before. And I think if you look at other sort of parallel situations, you do tend to see these technologies and adaptation of organisations is spearheaded in these kind of situations. Okay, so a question here about a project at the University of Leeds called eRehab, where they're testing new ways of delivering physio sessions. I haven't come across that, I'm afraid, so I can't really comment on that, but it certainly sounds that those kind of opportunities I think people are certainly going to be doing more of. I don't know about that specific project, but I will look to find out. Okay, so a question in the registration about leadership aspects of technology adoption, and in particular how this can be achieved successfully with remote working teams. So I guess that might be a question more about how team members can work with one another than maybe the sort of patient-facing side of things. Again, I think it's a question of understanding what the what people are trying to achieve from the technology and understanding the different needs of the different stakeholders. I certainly think there is some value, if you look at the literature on teamwork, people do find that actual remote teams have very particular barriers to working, and that actually, but actually in some cases having that face-to-face contact, if they've had it previously, can be enough to kind of hold the team together when they move to a remote working situation. I think one of my colleagues who ran one of these webinars last week, Matt, Dr. Matt Davis, talked a little bit about this kind of idea of remote team working and how that works. And I think a lot of the issues you see in other organisations and settings probably apply here too. This question about wondering whether there are any particular stakeholders that I think are underrepresented in the literature to the detriment of service delivery. That's really interesting because I think that actually often it's not that the stakeholders themselves are underrepresented, it's often that we, and you find this not just in the healthcare system by the way, but right across organisations, is often we talk about user-centred design, so we talk about how it's really important to understand the needs of the user, but very often we then guess what the user wants, and we kind of second guess what we think they're looking to use. So for instance, I know often we sort of guess that the patient, we guess what we think the patients want, and we guess what we think their parents want, their carers want, without actually discussing with them what they need. And I think that's where more needs to be done, because I think that's where the service delivery tends to fall. I think the value is in bringing those stakeholders together so that you can facilitate that conversation between them. Because very often people are very good at putting forward their challenges, but without sort of discussing those with the other relevant stakeholders and understanding how to avoid the trade-offs or how to overcome the barriers and work together. So I think that's potentially where the challenges are. And just related to that point as well, I think personally, I think there's also some interesting, we often get really quickly involved in the ethics of working with patients, and I think sometimes that can put, put people off working with patients because it's very hard to access them, because often the whole reason they're patients is because they're vulnerable, and so, it can be quite hard to engage with patients in active research projects, and so I think they can be underrepresented in the literature, maybe partly at least for that reason. Yeah, thank you. So yeah, definitely there's lots of things for me to look up, and just to say, it is a bit unfortunate because I can't hear questions. I'm having to sort of deal with questions in this way, but anybody who just want to sort of follow up with me afterwards, I'd be very, very happy to follow up over email or conversation if anything has struck an interest, or if there's things that you want to discuss or debate with me, I'd be really happy to do that. Okay, so just a question here about what are the opportunities for patients using alternative therapies or complementary medicines. Yeah, again, it all sounds really interesting. I think I would keep going back to the idea that actually the limitations aren't with the technologies and the therapies. I think we've got some really excellent therapies and so on, but I think the limitations are often with how they're embedded in the broader system, and often there's a place. I should be really clear, I'm not advocating that we scrap and purely move to a remote healthcare system, and I don't think anybody is, but I think it's just understanding at what point something can be, where does this fit, because at the moment it hasn't fit, it hasn't had a place, and I think it would be really interesting to understand more about where is face-to-face needed, but actually where are there opportunities for other lines of remote healthcare. Okay, yeah, thank you. Gosh, that has gone really, really quickly. So yeah, I mean, just my last thoughts, messages. I really appreciate you taking time to listen to this today. And as I say, I'm a bit sorry that I haven't been able to actually hear people's questions and have that discussion rather than just a Q&A. But if people do want to get in touch with me, I would be really happy to talk more about this. I think there's lots and lots of opportunities for further research, and I'm really keen to pursue that. So again, if you are perhaps a healthcare professional, you're interested in collaborating or working with the business school or myself, please come our way, and we'll be really happy to work together and hear about your ideas and thoughts. Thank you so much.